Good morning and welcome to our webinar. On behalf of the Centers for Medicare and Medicaid Services, CMS, Division of Tribal Affairs, DTA, in partnership with Children and Adults Health Programs Group, I would like to welcome everyone in All Tribes Consultation webinar. My name is Sherry Gay and I work for Kaufman and Associates. I'll be your moderator today. Today's webinar is titled Overview of Streamlining Medicaid Eligibility and Enrollment Notice of Proposed Rulemaking. Before we begin, I would like to highlight the main features of your Zoom webinar interface. First, the presentation slides will appear in the main window, while a speaker will appear in the top corner. At the bottom of your screen is the menu bar. Here you will find the chat, raise hand, Q&A, and closed caption functions. Please use the chat box to report any technical issues you are experiencing. We will respond to these concerns as they come in. Next to the chat box is the raise hand feature. You're able to use this during the Q&A segment to let us know when you'd like to unmute your mic so you can ask a question. Next to the chat box is the raise hand feature. You're able to use this during the Q&A segment to let us know when you'd like to unmute your mic so you can ask the question. Another way you're able to submit a question is in the Q&A box itself, where you can leave your questions at any point during the webinar for the presenters to address during the Q&A segment at the end. Lastly, live captioning is available for today's broadcast. Simply click the CC icon to use this feature. Please be aware that today's webinar is being recorded and that the recording will be made available online in the near future on cms.gov. With that said, I would like to welcome everyone to today's webinar. And at this time, I will turn it over to Beverly Lofton. Thank you.
Thank you, Sherry. Thank you very much. Thanks for the introduction. I'm Beverly Lofton. I'm a Senior Policy Advisor in the Division of Tribal Affairs here at CMS. Welcome to today's webinar. During this webinar, our presenter will provide an overview of proposed changes to simplify the process for eligible individuals to enroll and retain eligibility in Medicaid, the Children's Health Insurance Program, and the Basic Health Program. Participants can ask questions and make comments. However, for comments to be considered, written comments must be received either electronically or by mail no later than 5 p.m. on November 7th, 2022, following the instructions for comment submission as outlined in the Federal Register notice. And that Federal Register notice link was provided in the Save the Date notice that you all received. So today I am pleased to be joined on this webinar by Stephanie Bell and Jean Coffey from the CMS's Children and Adults Health Programs Group. So I'm going to turn it over to Stephanie to begin the presentation. Stephanie?
There we go. Thanks, Beverly. Hi, I'm Stephanie Bell. I'm a Senior Policy Advisor in the Children and Adult Health Programs Group here at CMCS, and I'm joined by Jean Coffey, who's a Technical Director in our Division of Medicaid Eligibility Policy, and he's really one of our key Medicaid experts. I'm going to start off, let's see, can we go to the next slide? Just doing a little bit of context about this proposed rule, and then we are going to jump into going through some details about the provisions. So next slide, please. As Beverly mentioned, the proposed rule comment period is open through November 7th. So we really look forward to getting your comments and urge you to please let us know, what you think, what you like, don't like, have concerns about, are excited about, etc. Next slide. So brief background. As we were looking at doing rulemaking, there were a number of things on our minds. First were these two executive orders issued by President Biden around strengthening Medicaid and the Affordable Care Act, and around strengthening access to quality and affordable health insurance, as well as the Affordable Care Act changes. So, starting with this premise of, based on these executive orders, of looking at opportunities to improve access, then looking next at what we had done based on the Affordable Care Act and the accomplishments that we've seen from the streamlined application and enrollment processes that we put into effect following that legislation. They've been really successful, but they have not been available to all Medicaid beneficiaries. Next slide. Two other things that were on our minds were, one, that we had started to see enrollment declines prior to the public health emergency and the continuous enrollment requirements in Medicaid that required people required states to keep people covered in order to claim a temporary FMAP increase during the public health emergency. Prior to that, though, after this steady increase from the Affordable Care Act changes, we actually started to see declines among children. So we wanted to, look at opportunities to correct that. And then the last thing that we were really thinking about, not the last thing, but the last thing I'm going to mention here is that we were seeing more program integrity concerns than we would have liked. So when the payment error rate measurement went back into effect for Medicaid eligibility after the changes from the Affordable Care Act, the rates of improper payments related to eligibility were much higher than we would have expected. And a big driver of that has been insufficient documentation. Next slide, please. So with all that in mind, we looked specifically for opportunities by which we could ease state administrative burdens, reduce barriers that keep otherwise eligible people from enrolling in Medicaid, CHIP, the Children's Health Insurance Program, or BHP, the Basic Health Program, and to, once they get enrolled, reduce unnecessary churning and periods of uninsurance for people who remain eligible. So we broke out the provisions in this notice of proposed rulemaking into basically these four buckets. This is how we've been thinking about them. The first are provisions that will streamline the application and enrollment processes, getting people in the door, making them eligible. The second are those provisions that will improve retention, keep eligible people enrolled at and between renewals. The third are looking at, what barriers are we specifically seeing for children and what can we do to address those? And the fourth will be those program integrity, some things that we specifically included to look at the program integrity issues. So going to the next slide, I'm going to turn it over to Jean, who's going to start us off with the first objective.
Okay, hi guys. As Stephanie said, I'm Gene Coffey. I'm the technical director in the Division of Medicaid Eligibility Policy. And yes, I'm going to cover some of the salient features of our NPRM and then turn it back over to Stephanie, and then we may do some seesawing. But again, I'm going to first try to address the first objective, which is to streamline application enrollment processes. Next slide, please. Okay, hang on one second. Bear with me, folks. Okay. One of the primary things that we are trying to achieve, well, I shouldn't say primary, but certainly a focus of our concern, a focus of our goals here with regard to the NPRM is to facilitate the enrollment process, the eligibility processes for those individuals whose Medicaid eligibility is determined by use of what we call the non-magi methodologies. Many of you may be familiar with the financial methodologies that are applied to determine Medicaid eligibility. The Affordable Care Act mandated that most Medicaid beneficiaries, specifically those who historically have fit the profile, so to speak, of the AFDC populations, the former AFDC program populations, that those particular individuals have had to, or now post the enactment of the Affordable Care Act, have had to have, if I'm saying that correctly, their financial eligibility determined by use of the modified adjusted gross income rules of the tax program, the US tax program. Well, many individuals still have their financial eligibility determined by use of the cash assistance methodology. And I'm thinking specifically about not exclusively, but predominantly those individuals who are seeking to establish Medicaid eligibility on the basis of being 65 years old or older, or having blindness or disability, what we sometimes just generally refer to as the SSI populations. And again, one of the goals here of the NPRM is to facilitate their enrollment, their application processes in the same way that the Affordable Care Act ultimately facilitated the enrollment processes of the MAGI-based populations. And the first element of the NPRM here is the facilitation of enrollment into the Medicare savings programs. If you're not familiar with the Medicare savings programs, or, as we typically refer to them as the MSP programs, these are the eligibility groups that cover through a state's Medicaid program some or all of the cost sharing that is applied or imposed against individuals who are Medicare beneficiaries. In other words, if you are a low-income Medicare beneficiary, your state Medicaid agency will cover all or at least some of the costs of your Medicare cost sharing and premiums. And again, one of the primary proposals here in our NPRM is to facilitate the process of the MSP populations. And the first element here is with regard to those individuals who have been determined to be low-income subsidy individuals. Again, some of you may be familiar with the Medicare Part D program, which covers the prescription drugs of Medicare beneficiaries. They have the Medicare Part D program has a low-income subsidy program, meaning that those Medicare beneficiaries who are low income can have a subsidy paid for their enrollment into a Part D plan, so as to have their prescription drug coverage provided, or at least subsidized by the federal government. Well, the LIS program has, the low-income subsidy program, the LIS program has an income threshold of 135% of the federal poverty level. That is equal to the highest income threshold for the Medicare savings program. So basically, the MSP eligibility group's highest income threshold is equal to the LIS income threshold, which means that there ought to be a high degree of parity between those individuals who are enrolled in the LIS program and those individuals who are enrolled in the Medicare savings program eligibility group. But it's not the case. As you can see from the slide here, I think we've discovered or believe that there are approximately 1 million individuals who are enrolled in the Medicare Part D LIS program who are not enrolled in a Medicare savings program eligibility group. And so what we proposed here is that states facilitate this enrollment for the MSP populations. And by our proposal, what we are suggesting or proposing to require states to do is to use the information that is transmitted to them from the federal government when there is a new LIS eligible individual, to allow that information to serve as an immediate basis for a Medicaid application for a Medicare savings program eligibility group. There is an independent requirement in the federal law that states use that information that's transmitted to them automatically by the federal government for an LIS individual to start the process of a Medicaid application. However, what we've learned is that there are a lot of states that are simply sending an application to LIS individuals eligible in those states to begin the Medicaid application process. But we are proposing here to put the onus on states to begin that application process independent of the individual, and to use some of that information that has been transmitted to the state from the federal government to start plugging in the eligibility related information for an MSP group. Next slide, please. Okay. And here we just have a little bit more information about the facilitation of the enrollment of the LIS individuals into an MSP group. We would require states to allow self-attestation of income and resources. We would try to align as much as we can the financial eligibility methodologies that are used to determine eligibility for the LIS program with the, yes.
Sorry, I'm seeing the objective 1 slide again. I don't know if other people are seeing. It looks like it may have gone backwards.
Oh.
Or maybe it's just me.
With the slide that
There we
should
go.
be, okay.
I think one more forward, right?
Yes, there we go. Okay, and here's just, right, a little bit more information about the facilitation that I'm talking about. Again, states would be, we're proposing that states would be required to do for some allowance for self-attestation of the financial eligibility information for prospective MSP enrollees. We would align some of the financial methodologies so as to ensure that the maximum number of people who are eligible for the Part D LIS program are also eligible for a Medicare Savings Program group. Next slide, please. Okay, here we have yet another feature of our effort to maximize enrollment into the Medicare Savings Program, one of those Medicare Savings Program groups. The lowest income threshold for the Medicare Savings Program population, the qualified Medicare beneficiary eligibility group, it has an income threshold of 100% of the federal poverty level, meaning anybody whose incomes are not greater than 100% of the federal poverty level will qualify in the qualified Medicare beneficiary MSP group. And that is the most generous of the Medicare Savings Program groups. It covers not just some of the cost sharing for beneficiaries, but any premiums they are charged as well. Well, 100% of the federal poverty level exceeds the income standard in nearly every single year for the Supplemental Security Income Program. In fact, I don't think we're aware of any year in which the SSI federal benefit rate was greater than 100% of the federal poverty level. And so what we are ultimately proposing here is that most states would be generally required to automatically enroll their SSI population into the QIMBY eligibility group and require nothing else of the SSI beneficiaries. Again, we have a contrast here where while everybody who is an SSI beneficiary will or should be eligible in the QIMBY group, as you can see from the slide here, we have approximately, at least so far as we know, 500,000 people in the country who are SSI beneficiaries who are not enrolled in an MSP group. And so we're looking to facilitate the eligibility of those who are and should be enrolled in an MSP group. Next slide, please. Okay, yet another feature of our effort to enroll prospective or would-be eligible MSP group people into the MSP program. There are a number of individuals who actually are not eligible for premium-free Part A, meaning that when they turn 65 and are otherwise eligible for Medicare, because they do not have a sufficient earnings record with the Social Security Administration, they are not entitled to have their Part A covered automatically by the federal government. And instead, in order to be eligible for Medicare, they actually have to pay the Part A premium, which can be rather exorbitant for people who have low income. And we've historically permitted individuals who are in that particular circumstance to seek conditional eligibility for Part A, meaning that they apply for Part A with the Social Security Administration contingent on them qualifying for the qualified Medicare beneficiary eligibility group under their state Medicaid program. those individuals who qualify through this condition in the Quimby group by way of this conditional enrollment into the Quimby eligibility or the conditional enrollment into Part A, in some states cannot have their Medicare Part A coverage begin until July of a particular calendar year. Well, what we're proposing here is to allow states in those particular examples where an individual's Part A coverage would not begin before July of the calendar year to make it effective earlier, at least in the month, no later than the month following their Part A conditional enrollment. Next slide, please. Okay, here's the big ticket item of our NPRM. We are looking to help prospective medically needy individuals enroll in the medically needy program through the deduction of their incurred medical expenses, the prospective deduction of their incurred medical expenses. If you're not familiar with the medically needy are those individuals who are otherwise eligible for Medicaid, except that they have income that is too high to qualify. And in states that cover the medically needy, the medically needy qualify by producing for their state Medicaid agency evidence that they have medical liability, medical debt that is equal to the difference between their own countable income and whatever the state applies for the medically needy income limit, what we call the MNIL. So for example, if a state's medically needy income limit is $500 and an individual has $1,500 in countable income, that individual has to demonstrate to his or her state agency that he or she has $1,000 in medical debt in order to reduce that individual's income to $500 and qualify as a medically needy individual. Historically, we have permitted individuals to project their expenses. Instead of actually providing the documentation to a state agency that they have the sufficient medical debt to reduce their countable income to the MNIL, if they happen to be in a medical institution like a nursing facility where the amount of the charges, their medical debt is consistent each and every month, that we permitted states to assume that the individual will incur those expenses, and where the projection of those anticipated institutional expenses is greater than the amount of an individual spend down, the individual can qualify on the first day of any budget period. We have not, however, historically permitted states to do that for non-institutionalized individuals, which as we've reflected on this particular fact, we've concluded that this could be another element of what is sometimes referred to as Medicaid's institutional bias. And so what we are proposing in the NPRM here is to allow state Medicaid agencies to project the community-based medical expenses of those individuals who are not in institutions and who are seeking to qualify in the state's medically needy eligibility group. And on the next slide, I think we have an example of how this would work. Yes, okay, so if we do have an individual with $1,200 in monthly income and the state has a medically needy income level of $700, well, the difference obviously here is $500. And if a state has a medically needy budget period of 3 months, well, then what's going to happen is an individual is going to have to document that he or she has $1,500 in medical expenses in order to be eligible as medically needy. And as you can see here from the slide, under the current regime, if, for example, the individual's 3-month budget period begins on January 1st of a calendar year, the individual, in order to qualify as medically needy, again, is going to have to document to the state agency that he or she has $1,500 in medical debt. If the individual does not establish that until, for example, March 1st of the calendar year, the individual will only be eligible in the budget period beginning on March 1st through the end of March, the end of the budget period. And then the process will start over again beginning in April for the next 3 months. And the individual will have to reestablish $1,500 in different expenses in order to qualify again as medically needy. Well, again, what we're proposing here is that if the individual's community-based expenses are so, if they can be reasonably anticipated, if they are constant and predictable, then we would permit the state to assume, beginning on January 1 for that 3-month budget period, that the individual will in fact incur the medical expenses that are at least equal to $1,200 and make the individual eligible on January 1st through the end of the March 31st 3-month budget period, and then do the same in the subsequent budget periods. Again, this would be a way to attack Medicaid's institutional bias. It would facilitate eligibility for those who have to spend down, and it would also reduce the administrative burden for states that have to typically collect the medical expenses during each budget period and having to do all of these different calculations for their medically needy population throughout each and every budget period. Next slide, please. Okay, I am way past the amount of time that I think Stephanie wanted me to be speaking here. Let me just say reasonable compatibility. Again, this was a feature of our post-ACA enrollment simplification processes, whereby we, or the federal law and through our regulations required that states use data sources in order to verify the financial eligibility of prospective Medicaid beneficiaries. We wanted to reduce, the federal law wanted to reduce the amount of effort that the individuals themselves had to make to produce documentation for their state Medicaid agencies. And what we instructed is that states, in using these data sources, if the information that they collected from the electronic data sources was reasonably compatible with the information that was self-attested by an individual. For example, if both the data source and the individual self-attested information established both that the individual has income below an income threshold for a particular Medicaid eligibility group, the state has to accept that information and not require anything else of the individual. Our regulations have been clear that the reasonable compatibility policy applies at least to income eligibility determinations. It was not clear, however, that the reasonable compatibility principle, the rule, applied to resource eligibility determinations. And what we're proposing here is to confirm that the reasonable compatibility rule does apply to state resource eligibility determinations. So, for example, if a state captures an individual's resources through application of the asset verification system, and the AVS determination, or at least what the AVS shows, is that the individual has countable resources below the resource threshold, and the individual self-attested resource information reveals the same thing, the state cannot require anything else of the particular individual. Next slide, please, Stephanie. Verification of citizenship. There is as many of you know, some citizenship verification requirements that apply to the Medicaid program and other federal public benefit programs. Under our regulations, there are some examples of documentation that an individual, if providing to the state Medicaid agency, does not have to provide anything else for. I think that the phrase that we typically use is the standalone sources of citizenship verification. And what we're proposing in this regulation is to add to the standalone elements of the citizenship verification to include, as you can see from the slide here, a state's vital statistics agencies or DHS's system, the SAVE program's verification of citizenship, that where an individual has these can produce, or that these particular sources can be consulted and used they can be independently used to verify an individual's citizenship without requiring anything else of an individual. Next slide, please. Okay, remove requirement to apply for other benefits. Dating all the way back to the 1970s, our regulations have required that Medicaid applicants and beneficiaries apply for other benefits for which they may be eligible or entitled. And it was a rule that we adopted to make our program, the Medicaid program, consistent with the other federal needs-based programs like the AFTC program and SSI program. It was not statutorily mandated, however. And what we've, upon again reflection, concluded is that in some circumstances, it's just an unnecessary barrier to Medicaid eligibility because some people are not even subject to an income test for purposes of their underlying Medicaid eligibility. Other individuals, if they apply for the benefits for which they must under our current regulation, might get income that will not be counted under their particular financial methodology. And so what we proposed here is to just get rid of the requirement altogether. I mean, we've offered states that still want to apply the requirement some midway examples of how we could potentially retain this requirement, but in kind of a slimmed down way. But we're ultimately proposing here that we would just get rid of the requirement altogether. Next slide, please, Stephanie. And finally, the proposal here to remove the optional limitation on the number of reasonable opportunity periods. And this relates to citizenship verification, where an individual is otherwise eligible for Medicaid, but is having a little bit of trouble verifying their citizenship, has to be offered reasonable opportunity periods, a little bit of an extension to establish their citizenship. And what our regulations currently allow states to do is to limit the number of opportunities that an individual has to establish their citizenship. But what we're proposing here is that we would eliminate the requirement, or I should say the state option, to impose a limitation on the number of reasonable opportunity periods that an individual who's seeking to confirm their citizenship can have. I mean, there is a proviso, something we would allow states in limited circumstances potentially to maintain it under very discrete circumstances, but ultimately the proposal here is that we would get rid of it altogether. So with that, I'm sorry, Stephanie. I thought I was, trying to speak as quickly as I could.
That was great.
I took more time than you wanted me to, so I'll turn it over to you, and hopefully we can actually get through this slide and still have enough time for questions.
Not to worry. Jean had all the really complicated pieces on Medicaid eligibility requirements, most of which require a little explanation before you can really even get into the change. So I thought that was terrific. And please put your questions into, I don't know, is it the chat? Where do people, as we're going along, please don't hesitate. Sherry?
Yes, with the questions and
Remind us.
answers, please.
Thank you. And yes, these slides, I know we are going to share them. These are the same slides that we used for an all-state call. So I know they're already posted on Medicaid.gov. And if you go to where all of our all-state calls slides are, but I think, are we able to share them through this webinar as well?
We can share them through the chat, and this is a recorded webinar, and it will also be on cms.gov.
Oh, excellent. Okay.
Yes.
So let me move in. Thank you. Let me move into the next section, the next objective on improving retention rates. So once we get people through the door, we want to keep eligible individuals enrolled. So going to the next slide. We know that many people fall through the cracks, particularly at renewal, and they end up losing their health insurance for a period of time. Often because Medicaid has very much been based on, paper documentation, paper renewal forms, paper notices, and people get those in the mail. And if the agency needs something else to renew their eligibility, and they don't realize it in time, that envelope has an important request in it, they don't get it back to the agency in time, they can lose their coverage even though they otherwise meet the eligibility requirements. So some of the things that the Affordable Care Act did, as Jean was explaining, mostly targeted to the MAGI populations, was to simplify some of the renewal requirements. So requiring that renewal forms be pre-populated with available information, so people only have to provide information the agency doesn't already have. Requiring that a minimum of 30 calendar days, in order to return the form. So making sure the person has time to, open the envelope, get the information needed, and send it back. And then what we call the reconsideration period. So if the person doesn't act timely to send back the needed information, and the agency closes their case, terminates their eligibility, they have 90 days from that date in which, if they send back that form and the information needed, the state has to reopen their case, can't require them to reapply and go through the whole application process again. The issue, though, is that these policies were only mandatory for those beneficiaries whose eligibility was based on MAGI. So all the folks who are eligible because they're 65 or older, or they have blindness or a disability, were not necessarily receiving these protections. And so through this proposed rule, we would require that those streamlined processes be provided, made available to all beneficiaries. So everyone would get pre-populated renewal forms, have sufficient time to return their forms, and then have that protection if they didn't get them back timely. Next slide. Similarly, we are clarifying and codifying those same types of protections for changes in circumstances. So the prior slide was really about that, every 12 months a beneficiary's eligibility needs to be renewed. Well, in between those 12 months renewals, if they experience a change, they're required to report that change. The agency may also, get information on that change through other mechanisms. And so they would then need to act on a change in circumstances. So we require in this rule that we would require that the state also, again, go through the process of checking available data sources to make sure the beneficiary still meets the requirements, reach out to them, provide at least 30 days notice for them to provide any additional information that's needed, and then make that same 90-day reconsideration period available. Next slide. So this provision comes from the work that we have been doing with states to unwind some of the protections that have been in place during the public health emergency as we look toward the eventual end. And one thing that has become even more of an issue is returned mail. And I understand that states, already before the public health emergency would have rooms full of returned mail where the notices and the information they sent to beneficiaries, requesting additional information, came back because the person had moved. This has become, as states have, delayed renewals because of the public health emergency, and people have moved more because life has been much more turbulent. There have been a lot more changes. And so we are proposing a set of requirements that we have been working through with states, through which we propose to require that states take a certain number of concrete steps. So obtaining updated information, going to managed care plans and other benefit programs, other trusted data sources to see if they have a new address for the individual. If they don't find a new address, using other forms of outreach to try to contact the individual. So if they have a phone number or an email, not just sending another form to the address that is already on file and isn't working, but also sending an email or calling or texting. Then looking, really trying to make sure that we've taken, or the state has taken all available steps to try to reach the person. Next slide. This last provision here in this section is about, going back to what I mentioned earlier about how we started to see a decline in enrollment of children. We started to look at, could they be falling off when they should be transitioning from Medicaid to a separate CHIP program, and some states have a separate CHIP. So we are proposing to streamline that process to, rather than, okay, the Medicaid agency finds they're over income, sends them a form, they confirm they're over income or they don't, terminates their coverage and sends them to CHIP, and CHIP then looks at them, does another determines their eligibility and then enrolls them. We want to streamline that process, see if we can cut out some of the part in the middle where we may lose the person because they don't either make it to the CHIP agency or they don't send back additional information that they may be asked for. So we're looking to have, in the example I provided, the Medicaid agency, when they determine they're no longer eligible for Medicaid because of an increase in income, would look and determine that they are eligible for CHIP, using as much available information as they can. And then once they've determined their eligibility, send them over to the separate CHIP to be enrolled. Next slide, please. All right, I'm going to toss it back to Jean briefly. And let's see, we have 19 minutes. That should be
Right,
enough.
so I will try to speak quickly for the next 4 slides in this section. I mean, ultimately, 3 of the first 4 slides are about the ways that we propose to maximize CHIP eligibility and to facilitate eligibility into the CHIP program. So let's begin. Next slide, please. The proposed elimination of a CHIP waiting period. Just so everybody knows, there is a state option to impose a waiting period of up to 90 days currently in our regulations for the CHIP program. And what we're simply proposing here is that we would eliminate this option from the regulations so that states could not impose any waiting periods, which clearly is a way in which CHIP eligibility could be facilitated. Next slide, please. Okay. We would also propose to remove the state option to impose a lockout against individuals who are seeking eligibility for the CHIP program or at one point established eligibility for the CHIP program and have unpaid premiums. Again, our regulations presently allow states to impose a lockout against those individuals until the premiums are paid, but we would propose to eliminate the lockout feature or the lockout option so that individuals who are eligible for the CHIP program can be enrolled in the CHIP program, can have their eligibility maintained. We would propose some options here for states in these particular circumstances, like, as you can see from the slide, the generating of frequent reminder notices and some other options. But ultimately, again, we are proposing to eliminate the lockout option from states for their CHIP program. Next slide, please. Then there's also the state option to impose an annual and lifetime benefit in the CHIP program. There are certain coverage requirements that cannot be limited, as you can see from the slide here. The Mental Health Parity Act prohibited a lifetime benefit limit for certain behavioral health benefits, but outside the behavioral health benefits, states have been in their CHIP programs been permitted to impose the annual lifetime benefit caps. But again, what we're proposing here is to eliminate this option altogether so as to maximize the CHIP eligibility. And finally, I know I'm speaking quickly here, but we do want to provide some time for questions. This is very weedy. As I mentioned at the outset, there are different financial methodologies that are applied to determine eligibility.
Next slide.
Yes. Oh, did I not say it? Okay. Nope. Yes. Are we on the correct one?
Now jump into the weeds.
Right. Yes.
Or just stay at the high level.
Okay. All right. We are proposing in our regulations to confirm that there are some children who still may have their financial eligibility determined by use of non-Magi methodologies. And the reason why that's an advantage is because states can apply income and or resource disregards to determine the financial eligibility of those who are subject to non-Magi methodologies. That is not an option in a Magi-based eligibility determination. But again, what we're proposing here is to add to the regulation the confirmation that in some circumstances, states can still use non-Magi methodologies for certain discrete classifications of kids, which, again, includes the disregard authority, which we think would maximize and increase potential eligibility for the Medicaid program for children. I'll turn it back to you, Stephanie.
Thanks. Next slide. Time frames. Okay. So a couple of things that we wanted to do related to improving program integrity. One of them is timeliness. So looking at the challenges that can come into play when you look at the whole timeline of sending an individual a request for additional information, getting that information back from the individual, processing it, determining if there's still, if more information is needed, if the person now meets the eligibility requirements, that can take a long time. And so we proposed to establish specific timeframes depending on the circumstances. So currently, we only have a time frame in our regulations for application processing, that it must be done within 45 days for most applicants and 90 days, within 90 days if it requires a disability determination. So we propose time frames specific to different types of renewals. So if the state, so for instance, if the person's coming up for renewal and the state is able to renew their eligibility based on information they already have, that needs to happen by the date of the renewal. If the state needs to send the individual a request to return some additional information, they have to do that at a certain period in advance of the renewal date. Give the person that 30 days to reply and send the additional information. But if they don't submit it timely, but it's still within the period of time that the state, that their eligibility is in effect, before that renewal date, then the state needs time to be able to turn that around. So we provide different time frames depending on the different circumstances that are in effect. So both to give beneficiaries adequate time to provide information and to ensure that states have adequate time to process that information. Next slide. And then we really wanted to strengthen the record keeping regulation. So as I mentioned, the high rate of improper payments that we have been seeing is largely related to record keeping. And that's in part because our record keeping regulations have not been updated, I think, since the 80s. They are very out of date. They're based on a piece of paper and a file folder. And, that's just not the way that eligibility is determined, and records are kept for the most part now. So we're updating the regulations to require, to remove references to outdated technology like microfiche and to require that records be stored in an electronic format. Next slide. So that is an overview of all of the provisions in the rule. And I know that was a whirlwind, and we hope that you'll be able to use these slides as a resource when you're reading through the rule. We wanted to take a few minutes to talk about implementation timeframes because we're very interested in getting feedback on how soon these provisions should become effective once they are finalized. So recognizing everything that's going on in states with respect to the public health emergency and hopefully the eventual end of the public health emergency and resumption of routine eligibility and enrollment operations, we're interested in feedback on how quickly these provisions should go into effect. So our current thinking is that when the rule is finalized, it would become effective 30 to 60 days after publication, but we would set a later date for compliance with the requirements, which may vary by provision depending on the feedback that we get. So that would permit every state to implement all the changes immediately. It would also permit states that need more time to implement changes to have that time to make the necessary systems modifications. So as you're reading through the rule, please think about appropriate timelines for each provision and do comment on that. Next slide. Just a reminder that comments are due by November 7th, so that is not a whole lot of time left, but we really do want to hear from you. So please make sure if you have feedback that you submit it by that deadline. We're not permitted to accept any comments after that period. Next slide. Again, we need your feedback, so please take time, if you haven't already, to read through the rule and submit comments. And we have about a few minutes left for questions, I think.
Wonderful. Yes, this is the time for our questions. We'll first be addressing the questions already submitted, which was the slides, and do we have a link for those slides to put in? I did put the regulation.gov in for feedback, and that's due on the 7th, I believe you said, Stephanie?
Yes.
Okay, and that another way to ask questions is the question and answer box, and also to raise your hand. We can take you off mute and do that verbally. I will give everyone a few minutes to think about that and enter any questions that you may have. Tom, can we go back to the slide that had the links though, just so that people have that in front of them, and I can also put it in the chat? I know I missed one of the links. Thank you so much. It might be easier, Tom, if you just copy it and put it in the chat. That way I don't have a typo. All right, any questions from the group? This was very informative and a lot of really good information. I know that you guys, so one of the questions that came to mind for me was when you were going through this, that you had a lot of recommendations that you were submitting. Have they been submitted already, or when will they be submitted?
So everything that we've talked through was in the proposed rule, and we did seek comment on a number of things. So, you know, as you're reading through the way they're set up in the Federal Register, is the preamble is the description and the story behind the changes. And then at the end of the regulation, you'll find the actual regulation text, which becomes part of the Code of Federal Regulations when it's finalized. So reading through the preamble, you get the sort of the background and the thinking about each provision. And then throughout there, we ask a number of questions, you know, particular areas where we're interested in comment and had questions as we were thinking through. But we also, you know, welcome questions and comments on everything.
Wonderful, thank you. And so they can use this www.regulations.gov to submit comments. What about questions from this slide? Do you have a way that they can reach out after things kind of settle into their minds?
We do.
Go ahead.
Sorry. Yes. You can. When I will talk about also in the closing remarks that folks can reach out to the Division of Tribal Affairs, and then we'll be able to send the comments over to Stephanie and Jean if anything comes through.
Perfect, wonderful. Okay, any questions from the attendees? We have just a couple more minutes. I would love to hear anything that you may have in the chat or in the question and answer box.
Can you also, Sherry, remind folks how to raise their hands if they want to raise their hand to speak?
Absolutely. At the bottom of your screen, there is an option to raise your hand. It's located at the bottom as it is displayed on the screen. So if you want to do that, we are more than happy to call on you and discuss whatever is coming to mind. We have a quiet bunch today.
I think it was a lot to unpack and think about.
It was very good and a large amount. Yes, can we get a link to the slides so we can print them? I know that this is being recorded and will be on cms.gov. However, is there another link where they can get these slides specifically?
So we will provide the slides with the recording once the recording becomes available as well. As many of you know, that sometimes we cannot provide the slides, but for these particular slides, we've been given approval to provide these slides.
Wonderful, thank you. Any other questions? All right, well, with that, I'm not seeing anything else. I would like to remind everyone that today's webinar was recorded and that the audio and presentation slides will be available online, cms.gov. I will put that in the chat as well. And I thank you for coming to our webinar. And if you have any questions, please reach out to your tribal. And I will hand it back over to Beverly to close us out. Thank you.
Thank you, Sherry. Thanks so much. And thanks again, Stephanie and Jean, for your wonderful presentation. You did a great job, very informative. Folks, I also want to thank participants for joining us today. In the save the date notice, you will find the link to the Federal Register notice as well. I know we put links in the chat, so please remember to submit comments before November 7th, that date at 5 p.m. And that way, that's how comments will be considered. They won't be considered any other way unless you submit the comments through the Federal Register, okay? And as always, you can submit inquiries to the CMS Division of Tribal Affairs mailbox, and that can be found at tribalaffairs@cms.hhs.gov. A recording of this webinar will be posted on go.cms.gov/AIAN, and we're also going to post the slides there as well. So with that said, have a great afternoon and thanks again for joining.
Thank you. Have a wonderful day.
You too. Bye-bye.